Thanks everyone for coming to our October meeting, the last one before the end of the calendar year and the holidays. We appreciate you.
Yes. Alrighty, can everybody see my screen?
Yes.
Thank you, lovely. Alrighty, all right, welcome everybody, like Dr. Martin said. Let's get this out of the way. Okay, so IV lab updates for the month of October. We had Catherine present her poster on education needs assessment from first-year medical students at VCU. I want to put this somewhere so you guys can see everything. Okay, great. But yeah, she presented her poster at the Network for Undergraduate Research in Virginia this past October 26th at the Virginia State University. There's her and her lovely poster she worked so hard on. And then we also have a published manuscript from Jonathan Jacobs on profiling the sleep architecture of aging adults using a 7-state continuous time Markov model. So yay. And then the students presenting their posters today, all of their abstracts got accepted to the Virginia Society of Addiction Medicine, and they're going to be presenting this weekend on Saturday. So we welcome all of your questions just to help them get prepared for game day on Saturday. Also, the following weekend, we have a lot of MRSA accepted abstracts that will get presented then. And then here are our manuscripts in review. Quite a few. I think all of these are the same from last meeting. But here is our Twitter page and handle, the YouTube channel handle, if you're not already following, in our LinkedIn. And then we finally got our Instagram up and running thanks to our lab member, Arjun. He's been working absolutely like super hard on all of the social media stuff. So definitely follow us on all of the handles if you haven't already. Up and running, we're active. We want to engage with you guys and interact about all of the stuff that we post. A new study that we have going on and is called CBTIO, and that is adapting cognitive behavioral therapy for insomnia, specifically for people with opioid use disorder. We're currently in the pre-testing phase, so we're not recruiting, we're strictly just planning the study out and getting all of the IRB documents sorted out. But this study is using sort and registry data. I'll go into those projects a little bit in a second. But yeah, that's being led by Michelle. And then here, Project Sort is one of the data that we're using for CBTIO. This project is investigating the relationship between sleep and opioid use disorder recovery. The study is the recruitment is complete and chart reviews are ongoing. And we have a list of the students in the lab that are working on this. And then we have the registry study also being used, data is being used for CBTIO. And this is an ongoing record to track clinical outcomes of pregnant and postpartum patients who seek addiction treatment with our OB Motivate clinic. We are continuing to enroll patients into this study. We have 151 so far, and then a list of students also working on this project. And then Project Castle is developing a computerized intervention that educates pre and medical professionals on substance use disorder stigma. They have a manuscript in preparation and are very close to finalizing it to get submitted to a journal by the end of this year. So that's very exciting. And then the educational studies, this is what Catherine did her poster presentation on this past weekend. I think the 26th was a weekend, but but yeah, she did her poster on the data from the educational studies, and the clinical research curriculum is still ongoing. And then here is our pending research support. And then this will be the last time the lab meets all together until the new year. So I will send out an invite to everybody when that date gets closer in January, probably towards the end of January. So we'll have a little bit of a break for November and December. And if anybody has any questions about the studies or anything that's upcoming, just reach out to me and we will get all of that sorted out. So,
Thanks, Amber.
mhm.
Yeah, that's great.
Now for the presentations. Does anyone want to go first? Amanda, Shreya, Luke, any takers?
I can go first.
Amazing.
Do you want me to just share my screen?
Yes, that would be great.
Okay. Um, let's
Are you ready for this weekend? Are you nervous at all, Luke?
I'm a little nervous, but I think it'll be good.
Yeah.
So let's see. Okay. It's
Dr.
confusing.
Martin, did you decide if you were going to be able to make it on Saturday?
No, I'm not gonna be able to make it. I'm sorry, y'all. But there are lots of people I know who will be.
Mhm.
I've asked all of them to take pictures. So you're a
Yes.
lot of people taking photos of you. I apologize. I'm gonna be out of town with my family this weekend.
Oh, good. But yeah, bunch of pictures, so be pretty.
Get ready.
Yeah. All right, we're ready.
Okay, you can all see the screen?
Yes.
Okay. Well, first of all, it's so good to see everyone. Haven't seen everyone in a little while, so good to see you all. I will just start. So, hi everyone, I'm Luke. I'm an M2 at VCU, and my poster is on gender-specific associations between chronic pain and insomnia among adults with OUD. And so, by way of introduction, so chronic pain and insomnia are both common in people with OUD. However, little is known about the association between those two aspects of OUD, and if there even are associations to start out with. However, in 2022, there was a study published that looked at chronic pelvic pain, and it did establish a relationship and association between chronic pain and insomnia in people with OUD, one of Dr. Martin's studies. And so this study can be looked at kind of as a follow-up to that almost, and kind of like a tell me more about the specifics of the sleep associations. Like, tell me about the specific insomnia symptomatologies that are related to that chronic pain. And so that's the objective, is to explore the associations between chronic pain and specific insomnia symptomatology by gender in this population. And that is important because women and men experience chronic pain differently for a variety of reasons. And so we wanted to look at it by gender. So getting into the methods, so how we did it is we did a secondary analysis of a cross-sectional study that was done, the SORT study. And so that was a cross-sectional study of people aged 18 to 65 with OUD who were stabilized on buprenorphine for 6 weeks at the outpatient substance use clinic. And so how we did this really is in the SORT study, the people who did that, and our sample size was 130, they did a screening form where it asked them about all their, if they had a chronic pain diagnosis, such as fibromyalgia or lower back pain was another common one. And so if they had ever had a chronic pain diagnosis, that's how we said whether or not they had a chronic pain diagnosis. And then they also did filled out the ISI screening test. And so Based on that they all filled out in the SORT study, we ran, Michelle ran chi-square and t-tests to look at the data. And so for the results, if you look at figure 1 first, this answers the question. There was in this population a gender specific difference in ISI scores by chronic pain that was present in women with chronic pain as opposed to women without. And so that was present in women and it was not in men. A statistically significant difference. And so then if we look at table 1 to go into specifics of that, if you look at the third row, early awakenings specifically was also, there was a statistically significant association in women with chronic pain compared to women without, that was not present in men. So for women with chronic pain, 82.4% of them had early awakenings. And so that is a direct answer to the objective that we had of looking at specific insomnia symptomatology, because early awakenings in women with chronic pain was a statistically significant finding. And so, kind of discussion conclusion, in this sample, we did find that statistically significant association in women that was not present in men, and we were able to identify early awakenings as a specific symptomatology. And we don't want to like overstate our findings, but this potentially down the road, this could have impacts on treatment, and it would be great if future research explored this further to try to expand on this association, so that we can help people with OUD who have these to get better treatment in a gender specific manner. So thank you so much.
Awesome job, Luke.
Thank you.
So kind of pretending that you're going to see Luke's poster. What questions do people have that they would potentially ask him at the conference, or clarification or any feedback?
I'm sorry, maybe I should reshare.
Yeah. Deshonda asked you, Luke, how gender was defined or assessed on the survey. That's a good question, given that that's your independent variable.
Yeah, so all of the women, all the people in this study identified as cisgender. And so I believe that it was like the first question on the survey, and it was just a box that they checked. Is that right, Michelle?
Yes, in the demographic survey, they're asked how they identify. And so, I mean, not great for representation of like the overall sample, but everybody identified as a cisgender man or cisgender woman. It would be cool to, explore with like gender non-conforming people, but yeah, that is how we identified as men and women in the sample.
Okay, great. Thank you. I was just wondering, the wording of the question and then the options that were provided are sometimes important. So thank you.
So my understanding was that there just wasn't a box for any other gender identity, correct? Either Michelle or Luke for the sort data?
No, there was. So in the demographic
Okay.
survey, there were options like cisgender man,
Okay.
gender woman, like gender non-conforming person, transgender man, trans
Mhm.
woman. So those were they were all options, but just
Amazing. Okay.
those, cisgender man or cisgender woman. Yeah.
Great. It may be important to have that exact wording with you or have that question with you when you're doing it, especially since it's is in the title and everything like that. It's important to note how those options were provided.
Thanks so much for bringing that up. Okay,
Yes, great feedback.
thank you.
Luke, I have a question for you. Just like your thoughts. Why do you think there was significance with the early awakenings in women with chronic pain, but not men? Just curious why you think that might have been found. No right or wrong answer, just curious.
Why?
Yeah, any ideas?
I do not know exactly why. I know that women are more likely to experience chronic pain.
Mm-hmm.
That specifically, I haven't seen that in previous literature, and so I'm not sure. If anyone has anything to add, I'd be really curious to hear if there are any thoughts on that.
Yeah, no, that's a completely acceptable answer.
Hi, Luke. My name's Margie. I'm one of the nurses in the clinic. Thanks for your work. I'm just curious. I know this is for non-pregnant individuals. Were the women, were they a certain distance from giving birth? Like they had not given birth in the last 3 months, or do we know, were they not in that first year after delivery? I just think of having to get up because of a little one, and then if you're in pain and you can't get resettled and back to sleep. Just curious.
Yeah, I think that the criteria, the inclusion criteria was just not pregnant. I don't think that there was any specific time frame of kind of what you're asking.
Mhm.
Is that right, Michelle?
I will gently correct you, but they had to be at least 6 weeks postpartum.
Okay.
So not pregnant or at least 6 weeks postpartum, just because
Okay.
you're right, like, especially for sleep, pregnancy and being postpartum, especially early postpartum, can be like huge disruptors of sleep. So we wanted to look at sleep like in a non-pregnant, newly postpartum population. So that's why we excluded people who are pregnant or 6 weeks postpartum.
Okay. I wrote that down. I will for sure remember that. Thank you. This is so good. I won't tell anyone that at the conference.
No problem.
And Luke, I'll just I wrote down some feedback for you that I'll send you in the chat. But ironically, one of my feedback might be an answer for the one potential answer for Amber's question. Looking at your data, like just looking at the numbers and the percentages, not the p-values, that might be better to focus on. Because I think that the statistical tests are limited by the sample size because we kind of cut we cut the groups into like 4 different groups. So if you think about it, it's men, women, and then with pain, without pain. And so the numbers get really small. So I actually think the thing that's probably driving the difference in the p-values is actually a statistical limitation of the sample size. So if I was you, they're there that you have your p-values, like you got to have those, to get something classified as research really. But I would maybe just think about describing the percentages and the raw numbers when you're presenting your results for 2 reasons. One, what I just said. And then 2 is that this is a clinical conference. And so this is a clinical audience. So they don't care about p-values. They care about percentages. They're going to want to know, like, how many of my patients with chronic pain are having early awakenings? 82%. Like, that is what they want to know. Like 8 in 10 of my women patients that have chronic pain, which is like most patients with opioid use disorder, that they're seeing that's something I should be looking out for clinically. So thinking about your audience, tailoring your presentation to the audience of the conference is very important and a skill to learn. So this is a good example of how you could do that.
Okay, thank you so much for that. So then with that, would I even maybe get into like the percentages with men also? Or at least like it looks like difficulty staying asleep for sure for women because that 80% difficulty staying asleep with chronic pain also, but like, should I address that with the men side too?
Yeah, I think so. I think for
Okay.
me, what looking at these numbers, like one, clinicians are just going to be interested in your raw percentages. That
Okay.
they're going to care a lot more about that than they do about your comparisons and all that. The comparisons that we have are very scientifically interesting because they give us preliminary data for future research. But from a clinical audience perspective, they're going to just be interested in the raw percentages, like the 6 in 10 patients with chronic women with chronic pain or report difficulty falling asleep. Like that's a lot of people. So I would just describe, so for me, the early awakenings, like that's a lot of people in both men and women with chronic pain, but especially the women. And then the difficulty falling asleep, I mean, 60% of men are also reporting that too. So I think you can just look at them and then highlight the differences that you notice in the percentages, and then secondarily report on your p-values.
Okay. Awesome. That's super helpful. Yeah, I'll try to work on that, like remembering the audience if it's clinical, focus on percentages. Thanks so much.
Mhm.
Something else that I had or could foresee as a question that I think you have the answer to, so I would just have it in your back pocket, is asking about other different like functional aspects of insomnia. So those questions of like, are your sleep disturbances impacting your ability to function during the day? Like, how refreshed do you feel? People might be interested in your participants' responses to those questions as well. Because sometimes with women, we have them actually like experiencing these insomnia symptoms to a pretty good extent, but they're reporting less of a influence on their day-to-day life, which is kind of interesting. So yeah, I think, do you have that data just in case somebody asks about it? Or
Yeah, I think that is on here. I'm sharing my screen, so I don't want to go look, but I think that is on one of the charts. So I will make a note of that and make sure that I have that, because I don't have that down right now, but
yeah, I
okay.
mean, you don't have to memorize it or anything, but if there's anything interesting that you found from that, that can be a good discussion point when talking to people.
Okay. Awesome. Thank you.
Yeah, great job.
Alrighty. Just on time's sake, if anybody else doesn't have any pressing questions for Luke, I think we can move on to the next presenter. Thank you, Luke. Also, Deshonda has a couple minor points for you in the chat if you just want to look that over, Luke, too.
I'll check those out. Yeah, thanks so much, everyone.
Great job. All right, who wants to go next? Michelle, oh, not Michelle. Amanda, Shreya.
I can go.
Okay, amazing. Thank you.
Alrighty, let me share my screen. Okay, can you see it? Let me zoom in. Is that okay? Or I don't know how to put it into.
I think that's great. I think that's,
You can
or if you presenter view up at the top left. There we go. That's great. Looks pretty.
Sorry, can you guys, sorry, can you guys still see it?
Mhm.
Okay, sorry, I can't see you guys if I go in presenter view. And I like seeing your faces and my face as well. But anyways, hello, my name is Amanda. I'm an M2 student and I was in the Ivy Lab for this past summer. And my project is seeing the treatment, the nicotine use disorder treatment patterns in pregnant patients who are also receiving treatment for OUD. From previous literature, we know that smoking during pregnancy creates health risks for both the mother and the fetus, but it's particularly concerning because pregnant individuals with OUD have disproportionately higher rates of nicotine use compared to pregnant individuals without OUD. Research also shows that there are safe nicotine treatment options available, but not much is known about how much they're actually being utilized. And this is all important because tobacco cigarettes are still very prevalent and pervasive, and there's also rising popularity of electronic nicotine devices and other kinds of nicotine products on the market. So in terms of methods, this study was a retrospective analysis at the outpatient OB/GYN addiction treatment clinic, which focused on pregnant patients who are receiving buprenorphine for OUD. And our sample size was 95 patients, predominantly non-Latinx white, typically unemployed, and had at least one psychiatric comorbidity, the majority of the sample. So moving on to the results, we did find some interesting things. So we found that 2/3 of the patients in our sample size used nicotine, with the most popular being traditional tobacco cigarette smoking. And then after that, e-cigarette use was the next preference, but relatively low still. And dual use, so use of tobacco and e-cigarette, was pretty rare. When it came to actual treatment patterns and utilization across the board, nicotine replacement therapy, so this was the nicotine patch and the gum, was more popular than nicotine pharmacotherapy. Among cigarette smokers, about 23% of them used nicotine patches, while interestingly, none of them utilized pharmacotherapy. And e-cigarette users showed slightly higher treatment utilization with 25% of them using the nicotine patches. So overall, this study is consistent with previous research that there is low utilization of nicotine use disorder treatments across all smoking types. And also this shows that the prevalence of nicotine use is high in this population. I think this does show that there are, potential barriers, such as limited awareness to treatment options, gaps in provider counseling, concerns about the safety of the medication during pregnancy, and just other accessibility issues to receiving care. And the study shows that further research should be done so that targeted interventions can be made, considering patients' preferred nicotine use methods, more investigation into what really are the barriers to why this population isn't able to utilize the treatment. And then importantly, if nicotine use disorder treatment during pregnancy affects OUD treatment outcomes, and that would be seeing if it specifically affects buprenorphine treatment outcomes. And yeah, overall, this work can help to develop more effective and patient-centered approaches to treating comorbid nicotine use disorder and OUD during pregnancy. And that is my presentation. I'll welcome any questions.
Great job, Amanda. So yeah, any questions that people have?
I'm curious about if you know what the standard practice is in this clinic for offering nicotine cessation treatment during pregnancy. Is that pretty, like, is it meant to offer that to everyone who reports that they smoke, or is that generally skipped? Just kind of curious about that because we see these low rates of utilization.
Yeah, that's actually a very good question. So, in terms of like from the clinical perspective, so I haven't worked in the clinic, but I've had some experience with chart abstraction. So I've been able to see some of the charts, and to my knowledge, I've seen for most people that most patients that report smoking, that there will be something in the note that the provider did discuss it with the patient or did like provide counseling. So I do think it's standard, but correct me if I'm wrong, because I'm not totally sure.
Yeah, you were definitely going to get asked that question. And in my feedback, I was typing, Amanda, I was recommending that you make sure you read before Saturday just to refresh your memory on
Mhm.
the United States Preventative Services Task Force guidelines and those, because
Mhm.
there's going to be not people there who don't treat pregnant people commonly. And they're going to be like,
Mhm.
great, a pregnancy poster. Let me ask you all these questions about pregnancy. I'm assuming you're the clinical expert because you're in front of the poster. So just know that that will probably happen. So it's good to reread those. And in the clinic, you're correct, Amanda. We are probably better than any other clinic at talking with patients about a nicotine use during pregnancy. It's recommended, obviously, that every OB provider talk to every patient about that. But we're an addiction clinic, so like that's what we do. Like that's our jam is to talk about behavioral change and substance use. So what's concerning to me is, I think these rates are fine because a lot of patients don't want to quit or they don't want things to help them. But this is probably the best case scenario, I'm assuming. So something I would be curious about that you might get a question about, especially if it's a research person, is
Mhm.
how do these rates compare to other clinics that have been reported, like non-opioid use, non-substance use clinics? Like, what are their rates of their patients using NRT and other methods? I actually am curious. I will actually want to know the answer when you figure it out, because I'm curious about that. I bet Margie wants to know too. Because I mean, these are good numbers of people using it, but we talk to every single patient, every single visit about smoking cessation, and that is not the norm in other clinics. They're not spending as much time as we are. And we know how to bill and code for it too. And that's also included in the practice bulletin by ACOG, which you should read before Saturday, is like the billing codes. So people can bill for this. You just
Mhm.
have to document a certain way to get paid for it. So yeah, I think that's a good question, but the answer is yes, we talk to every patient, every visit about it. So this is probably a best case scenario. So it might be good to have in your back pocket, like Madison brought up with the last presentation, like a comparative number to a non-substance use clinic.
Okay, yeah, thank you. I
Yeah.
think that's a good idea.
The other question you might get, I just thought of, Amanda, is
Mhm.
when this data, like when these patients delivered, like what years these patients were from, you might want to have that on your poster because the whole e-cigarette thing is just such a rapid changing thing.
Yeah.
So including like the dates um that these patients were pregnant, just the general years would probably be good too.
Okay. Yes. I want to say off dome, I think it's 2022, but I will confirm.
All right, great job, Amanda. It looks great.
Thank you.
Any other questions from anybody before? Alrighty, if no one else has any questions from Amanda, we can go to either Shreya or Shreya.
Go. I'm not sure you want to go.
Go ahead.
Okay.
All right, Shreya.
Okay. Oh, I need to share my screen. That would probably be helpful. All right. Can everyone see?
Yes.
Okay. Okay. The video. Okay. Hi, everyone. My name is Sriya. Like everyone else presenting today, I'm an M2 here at the Ivy Lab, and I'm excited to share my poster with you all, which better understands. Sorry, I'm going to just hide these meeting controls. Okay, which looks at how resources are utilized here at OB Motivate across racial subgroups in our clinic. So just a little bit of background. I think it's a generally well-known idea or thought, but healthcare is not equitable between all people, particularly people of color, specifically people who are of Black or African American race or ancestry. Typically have poorer healthcare outcomes than people who are identifying as white or Caucasian. And that same idea, it comes from a lot of different reasons, things like social determinants of health, implicit bias, systemic racism. That same idea kind of extends into the opioid use disorder and substance use disorder space as well. Individuals of color typically have poor outcomes when it comes to things like receiving treatment for opioid or substance use disorder, completing outpatient treatment trials, etc. And essentially what I wanted to do with my project is kind of create a descriptive question to better understand how those ideas work in our clinic, our obstetric / addiction clinic here at OB Motivate. So the idea was like I did a secondary analysis of our current ongoing retrospective study, and based on that, we characterized individuals in our sample based on their race, which was my independent factor, white or Black African American, because those were the two largest groups that come to the clinic, and looked at a variety of resources that are offered here at OB Motivate, ranging from prenatal, during pregnancy, and even extending postpartum as well. And essentially looked at a categorical analysis of how these services were used between our sample. And just looking at the graph, which is sort of the meat of my poster, you can see that just qualitatively how resources are used in terms of things like anesthesia consultants, lactation consultations, things that are more centered during prenatal times, and then other things like mental health care, which can extend throughout pregnancy as well. And I think this might be the one time in medicine or science where a statistically insignificant difference is actually a good thing. And that was what the main finding was for my poster or my project, was like, essentially there was not a statistically significant difference in the way that our racial subgroups that we looked at analyzed or utilized OB Motivate resources, which is a good thing. It shows that our providers and our staff are doing a great job in making sure that every patient is receiving the care that they need and is being offered to everybody who needs it. In terms of things like my discussion and what I want to look forward to branching out for my project, I really want to look at more of the demographic factors, things like education, insurance, employment, and how whether or not someone has or doesn't have a certain demographic factor can affect the way that they utilize services here at OB Motivate. And I think that by being able to do this, it may not be able to answer the pressing question of why people of color may have worse healthcare outcomes than their white or Caucasian counterparts, but it will better give us a descriptive foundation to be able to better understand how things like social determinants of health and where someone lives and their education background can affect the way that they make healthcare choices for themselves during pregnancy and to treat their medical history in the arena of opioid use disorder. So that's that. I will see if I can pull you guys back up in the video.
Great
Take
job.
Thank you.
Yeah, I like how you just include your like next steps with the focus on the social determinants, because that's probably the most common question you'll get at a poster is like, oh, well, what's next? Or what are you going to do with this? That's like the common question that people ask you. So it's good that you already have that prepared.
Hello, this is Deshonda. This was great, and I think especially for a clinic that provides such great patient-centered care, that is kind of what you would hope for. Um, the way I see the poster, it looks like the bottom is cut off, so I don't know if that's something going on with my screen or like where it's like the end of the financial disclosures in the bottom of your. Okay, there we go. Okay,
Is it
maybe it
better
was
now?
just the.
It
Yes,
might have been
yes.
my like taskbar at the bottom that might have popped in.
Okay, I just wanted to make sure because I was like, oh, I don't want your poster to be cut off when,
Yeah,
if you have to
me
print.
too. Me too. Me too.
And then the other thing is I noticed that in your figure that third trimester was listed twice.
Oh,
Um, so I don't, but the bars look a little different, so I don't know if one was supposed to be, first or second trimester versus third.
no, you're completely right. I think that they might have also been referring to different things. And
Okay.
just because of, I tried to increase the font size to make it so that at least you could at least read it, and that probably got cut off. So if my poster is not printed yet, I will try and change that. Is it printed? Okay, then I will make sure to clarify that if someone asks me. Thank you for pointing that out.
No problem. And good job. Thank you.
Yeah, definitely. That's gonna be okay. You can just clarify that there was a printing mistake. So, but if no one draws attention to it, I feel like it would just be okay.
For sure.
Yeah. I do wonder though, maybe this is a question for Dr. Martin, but Shreya, just mentioning what you said, Dr. Martin, from Luke's poster, I wonder if you said this was a clinical audience and they're interested in the percentage and stuff. Obviously, there was no statistical significance in resource utilization between white and Black individuals, but in the figure, there is, I mean, it is notable that whites do use more than Blacks, but I wonder if it was just because in our sample size, there's more. I think, yeah, white individuals were represented twice um twice more than Black individuals, but then also again it was just quite a small sample size. So I wonder if in this sense it would be notable to do the percentages like you said for Luke's poster, or if just leave it at no statistical significance between the two.
I think for this one, you could still do what you did, Shreya. Like the overall service utilization was not different. I think have in your back pocket what that percentage is. And then you can probably anecdotally say, but like as you can see, when we broke it apart by service type, we do see some differences qualitatively, right? And you can have those percentages in your back pocket. But we didn't see an overall um, you know, overall substantial difference. But I think Amber is a good point about having those percentages because you do see it, especially in like the yellow at the very end,
Yeah.
So I think it's good for you to notice the kind of both. And yours is a little easier because you're like, well, our overall was this. And then when you broke it apart. So you kind of have it a little different than Luke does in the fact that you can talk about both, I think.
Sounds good. I will make sure to review the specific percentages.
Yeah, great job, Shreya. I want to make sure that Shreya has enough time for questions too, so we can transition to Shreya now. If that's okay with everybody else, if they don't have any pressing questions.
How do I stop sharing my screen? Oh,
There should be a red button. I think it's, yeah, there you go. Mhm. Thanks,
Alright,
Shreya.
I will share my screen. Thank you everyone for sticking around. Right, can everyone see it?
Yes. Great, beautiful.
Great. Hi everyone, my name is Shreya. I am also an M2 and I was working alongside Michelle this past summer on the SORT study. So my project title is Menstruation-Related Issues and Insomnia Symptomology in Women in Outpatient Opioid Use Disorder Treatment. So starting with a little bit of background and introduction, we all know that there's different treatment forms for opioid use disorder, and many of these can be life-saving. The one that this study focused on particularly were patients who were utilizing buprenorphine, which is a medication. And then we also know that amongst the various treatment forms, especially with buprenorphine, poor sleep quality has been identified as a significant factor in this treatment trajectory and process, along with a lot of other different factors. But sleep itself has been not as studied prevalently in the past and has been becoming more prevalent in recent studies, along with Michelle's study doing the SORT study. So this was one thing that I thought was very important because it's almost really hard to study sleep because you can't really get as much biological like markers and measures as you would with maybe other factors that impact treatment. A lot of it might be subjective, but we have found out that this can impact optimal outcomes and can often hinder retention rates and just overall subjective experience and quality of the treatment process. One thing that I was particularly interested in is the relationship between menstruation and sleep. And mainly this is because menstruation and sleep has been already pretty well established in the general population who don't have OUD or are not on OUD treatment. And the reason, the relationship that has been established is often that of a significant one that does impact optimal sleep outcomes. Generally, people who have menstruation issues or even just regular menstruation often find themselves not having great sleep outcomes. But what was interesting was that the intersection between menstruation-related issues and even just menstruation at all and sleep quality has not been studied really at all in OUD patients, which is very shocking because considering that OUD impacts women very significantly, I think menstruation is one topic that can be further studied. So I thought that exploring this area can potentially inform some more treatment approaches and just the way that we approach sleep and treatment in general for this population. So the primary objective is to identify if there's any prevalence of co-occurring sleep and in menstruation issues. And if there is, then to what extent are we seeing it? So my methods is that this study is a secondary analysis. It's from the cross-sectional SORT study, and it's mainly exploring the relationship between sleep and recovery among women who are receiving MOUD. And the inclusion criteria is that they must be between 18 and 51, primarily to kind of cut off for any menopausal patients. They must be stabilized on buprenorphine, they must speak English, and they have to be biologically female just to make it a little bit more easier for testing purposes. And the primary outcome is the ISI score, or what has been defined as the Insomnia Symptomology score. And these is from the Insomnia Severity Index surveys that the participants all filled out. And my methods continued are the independent variable is primarily the menstruation-related issues. So whether or not the patient is experiencing any menstruation-related anxiety, depression, or mood changes, any dysmenorrhea, otherwise known as painful menstruation, or menorrhagia, or heavy menstrual bleeding. And these are all self-reported. There was another section in these studies that had a clinical receipt, but these themselves were all subjective experiences reported by the patients. And so kind of delving into results, in table 1, I have a layout of the descriptive statistics of the study population with just the demographics of age and race. And then kind of predominantly mainly going into figure 1, although there was no statistically significant differences found between menstruation and sleep issues in this population, I thought one of the most important things to kind of bring attention to was just how many participants themselves are experiencing menstrual issues. And so within this sample of 69 patients, 44 of them, or 63.8%, were experiencing menstrual issues. And the most common subcategory of menstrual issues that they were experiencing were the menstruation-related mental health symptoms, that being the anxiety, depression, and mood changes, which I thought was really interesting. And kind of going beyond that and actually delving into the co-occurring menstrual issues and insomnia symptoms. Again, there was no statistically significant difference, but I think that can also potentially be attributed to a lot of things, including the fact that it was a relatively small sample size, but also just kind of displaying the results in a more visual format. We have the ISI scores on the far left. And then from there, we also have kind of the subjective specific experiences of insomnia symptoms. So there was difficulty falling asleep, difficulty staying asleep, and then problems waking up too early. And in those that were experiencing menstrual issues, even though it wasn't statistically significant, a lot of them did have problems waking up too early, which is kind of similar to what Luke was talking about with his study, but in comparison to the people who weren't experiencing any menstrual issues whatsoever. And so kind of going into the discussion based off of these results, there was really, in my opinion, a high prevalence of people who were experiencing both insomnia symptoms and menstrual issues. And I think what's kind of really the most important takeaway that I want to get from here is that just kind of going off the fact of how surprised I was when there was really like no menstrual research at all in insomnia patients, as well as those who are on OUD treatment. I think that there's so much more room to kind of study menstruation along so many other topics, you know, whether that's the treatment retention rates within these OUD patients. And if they aren't experiencing insomnia symptoms, then are there other measures that we can kind of use to factor in other sleep outcomes, even that I'm not personally aware of necessarily right now, but I definitely want to do more research into that. And that's kind of where I want to go with this, but that is my presentation. Thank you.
Good job.
Thank you.
Yeah. What feedback or questions do people have?
Hey Shreya, I actually did have a question regarding the how the different menstruation related issues was asked on the survey. Is it like yes or no? And additionally, especially just like with B and C, that the terminology looks very similar. So did it have like a definition like with painful menstruation or heavy menstrual bleeding?
So from what I remember exactly on the sort surveys, there was like a menstruate, or it wasn't a menstruation section. I think it was like what alongside other, or no, there was a menstruation section and there was also another section that had a list of medical conditions. And then included within those sections, it was like, please check all that apply to you. And then of those, it was the menstruation-related anxiety and mood changes, dysmenorrhea and menorrhagia. And from what I remember, I don't think it was like defined like as painful menstruation or heavy menstrual bleeding. I think those terms themselves were just on there, but it did kind of phrase it as in, have you ever been like diagnosed with, for the mood changes, I think. And then for the other ones, it was more so, are you experiencing these? But I will make sure and make a note of it before I go into that.
I had a related question. Great job. And this is very interesting. So just to clarify, for the menstruative relation issues or questions, I know you have to go back and look at it, but did you only include the ones where people checked, or were there more options?
So, oh, sorry, go ahead.
Oh yeah, go ahead.
So these were the only menstrual related things, aside from one checkbox that was like a clinical receipt of PMDD. And I think I had discussed this with Dr. Martin earlier, but that was more of like, have you ever received a clinical receipt? And I think these were just, are you experiencing it? So it's just more of like a subjective self-reported thing. So I think that's why I kind of excluded PMDD.
Okay, and the only reason why I was asking because I was just thinking of other symptoms such as like neurological effects, especially migraines and headaches and things like that, because I know that's common.
Yeah, those were definitely all on there.
All right, great, thank you.
Thank you.
And Shreya, oh, sorry.
No, go for it, Michelle. Maybe you remember.
Oh, yes, yes, yes. Okay, so yeah, for the questions on menstrual history, it was for my recollection, I'll have to pull it up, but like during your periods, is the flow so heavy that you go through like a pad or tampon in an hour? So it didn't like ask outright dysmenorrhea. And I think the one about like the that's the menorrhagia, but the dysmenorrhea asked like if pain was too bad to that it interfered with your ability to carry out your day-to-day functioning. So those were the menorrhagia and the dysmenorrhea questions. And I do actually think the questions about the mood changes was in the menstrual history sections because we asked before they start, do you have anxiety, depression, or mood changes? So that is all three of those questions are in the menstrual history section. We do have some of like endometriosis and PMDD in a different section around like chronic migraines. We do have that in like the chronic pain section, but Shreya, yours were just from the menstrual history section of the surveys.
No, you're very right. I think that was a classic case of, I don't remember what bias it's called, but I tricked myself into thinking.
No worries, yeah.
Yeah, I think I remember us having that discussion, Shreya, and we decided to only use those questions that Michelle just said, and not use the checky boxes. And in order to make sure that we were focusing on the patient-reported symptoms, not on diagnoses, because I would just give you a very more biased sample because so many people don't seek care for things, especially things related to the menstrual cycle, from a healthcare utilization standpoint. So I think I remember that we decided to only use those patient-reported questions, those
Yes.
items, I think.
Alrighty, great job, everyone. I think you guys are so ready for this weekend. You guys are gonna do amazing. So excited for you guys. Does anybody else have any overall questions about any of the presentations before everyone hops off? If not, I just look out for an email from me in the coming year. Everybody have a wonderful holiday season. Yeah, hope to see you guys soon at the next meeting. But you guys presenting, stay on for just a second because we can talk about when we can meet to distribute posters and stuff like that because I have your posters.